and I would like to start by acknowledging the traditional custodians of the lands that we all live and work on. I'm not in Darkinjung land, I'm actually up in Newcastle, so I'm in Awabakal land this morning. Just a couple of things to let you know that we are recording this session. That while Cindy is doing her presentations, please feel free to put some questions into the chat. But of course, as always, there's going to be plenty of time for you guys to interact and have questions together. And I will put an evaluation up at the end of the session as well. Cindy, thank you so much. I'll hand over to you to start the session.
Thanks so much. And kind of want it to be a bit more sort of collaborative and interactive as well. So feel free to jump in if you have any insights or questions or anything like that. So let me just get my notes up. So in terms of okay, so I also have an acknowledgement of country. So want to acknowledge the traditional owners and custodians of the land on which we meet today, which is Darkinjung land or Awabakal land, depending on where everyone is. And like to pay my respect to elders past and present and acknowledge the important role they play in protecting and passing down thousands of years of culture and wisdom to the younger generations. In terms of learning outcomes today, I'm hoping to just talk a little bit about what palliative care is, GP's role in that, the community palliative care team and what they do, and sort of considerations in palliative care assessment, general symptom management, bit of advanced care planning discussions, and particular population groups as well, and considerations there for palliative care. So recently I had a great opportunity to do a palliative care scholarship through the PHN. So PHN offers quite a few different scholarships. I think there's like pediatrics, geriatrics, drug and alcohol one. So it's a 40-hour sort of placement that's sort of spread across different areas. For myself, I did sort of 2 8-hour blocks in the hospital and then 3 8-hour blocks in the community, which was really good. It was a great experience, learned a lot, and would highly recommend to anyone who's interested. So just a bit more about the, I guess, community palliative care team and how it works. Whether you know this or not, I certainly didn't know any of this before I did the placement. So it's based in Long Jetty as such, and usually they have 2 palliative care staff specialists, sometimes just one depending on if they're short-staffed or not. And usually one covers sort of north, so it's more sort of geographical areas of Central Coast, and one covering sort of the south region. And usually there's about 11 nurses, so usually one nurse for each sort of 8 geographical regions on the Central Coast, 2 to cover the RACFs, and 1 for triage as well. Each nurse would usually have a caseload of, sort of depends, anywhere from about sort of 20 to sort of uppermost 40 patients that they look after. So when a patient is registered with the community palliative care team, they would do home visits and also telephone check-ins as well, depending on sort of what stage they're at and what their needs are. And they also have a great sort of allied health service, lots of physio, OT, social work, counsellors, including the bereavement team, and your cultural liaison workers. And I've put the little phone number in as well. In terms of things that they do provide, so can sort of discuss goals of care and advanced care planning, especially if it is more complex, as well as obviously providing sort of advice for symptom management through home visits and phone calls, and the allied health input as well if needed. Unlike community sort of nursing, they don't provide any sort of wound dressings or sort of extra services which would be offered through like a home care package as such. And they also mentioned they're more than happy to field a call from GPs if there is any sort of request for advice or not sure if the referrals are appropriate. They also do sort of discharge patients from community palliative care team, and that doesn't necessarily mean that they don't need sort of palliative care anymore, might not need it in future, but obviously with they might have sort of around 400 or more patients at any one time. They might consider it if the patient doesn't really need any sort of specialist palliative care needs, and that the GP might be happy to manage it if the symptoms are pretty well controlled. Or sometimes if a patient is not engaging too much or would still want to call sort of an ambulance or present to ED if they do deteriorate as well, in which case the hospital can re-refer if needed. And I like to just go to, oh, don't know if that's working, sort of what is palliative care? I had a Slido for this, but I'm not sure if it will work. So maybe we can just sort of type in the chat. Be curious to see what everyone's thoughts are on, what is palliative care. I'll look in the chat as well. Yeah, end of life care. Yeah, definitely. Big part of palliative care. And yeah, definitely managing symptoms in terminal conditions is an important part of it too. Yep, having lots of end of life care, symptom management, particularly pain is a big symptom as well. That's quite common, which is good. And care to ease the suffering of patients, not directed as curative. And spiritual support, yeah, that's a great one as well. Care towards the end of life that makes quality of life more important than quantity of life. Yeah, that's a great way of putting it as well. Yeah, lovely to see sort of all the different sort of inputs and ideas on what palliative care is. And yeah, definitely all of those are a big part of palliative care. So I guess a little definition I've sort of written down is that sort of holistic, often multidisciplinary approach to improving sort of quality of life in someone with a sort of life-limiting illness, and looking at addressing sort of physical, psychosocial, sort of spiritual needs as well as addressing those of their loved ones who might be on that journey too. And for this next one, if you want to maybe put in the chat box what sort of conditions might require palliative care input, whether it's in a specialist setting or in a GP setting as well. Yeah, non-curable, life-limiting conditions. Definitely. End stage, yep. End stage sort of organ failure, definitely. So including COPD, heart failure, liver cancer, yep. Cancer is coming up as well as a big one. Yeah, dementia is also important one. And yeah, neurodegenerative diseases as well. Motor neuron disease, Parkinson's disease. Yeah, this is really, really, really good. It's a great list there. Thank you, everyone. So yeah, pretty much reflected what I've sort of written here. Obviously not limited to these as well, but this is just a list of some of the conditions that you might consider sort of palliative care for. And then it can be useful to think of the question. So if my patient did pass away or die or deteriorate quite significantly in the next 12 or 6 months even, would I be surprised or not? And then I guess thinking about if you would say, no, I wouldn't be surprised, like do they need any sort of palliative care sort of consideration or input or needs as well? And then just curious to get everyone's thoughts as well about a GP's role in the palliative care domain. Certainly it can be multidisciplinary, so can have GP, whether the palliative care service is involved as well, sort of allied health as well, patients and their sort of loved ones can be a big part of things too. But what might a GP sort of play, or their role sort of play, grand scheme of palliative care?
Hi, Cindy. I thought I'd unmute. I
Oh,
suppose,
yeah.
yeah.
Feel free to unmute and talk as well.
Yes, it's not so quiet. Yeah, I think initially our role is to explain, is obviously doing the referral process and explaining to patients what palliative care is, because a lot of people think that, that means we're withdrawing all treatment, that's it, that's the end. But explaining it's for symptom control. And yes, I think education is the initial part of our role in the referral process.
Yeah, definitely. And that education is a big one as well. Sometimes there can be a connotation as well with people thinking palliative care is sort of purely end of life care, which it doesn't necessarily have to be. Sort of any life limiting condition, sort of whichever stage you're at, can sort of consider sort of palliative care as such. And because there's so many domains of palliative care, obviously end of life is a big one, but there's also a lot in terms of symptom management, that education as well about, what palliative care is and what it can offer. And as Chrissy mentioned, sort of that communication with that patient, the team, family, especially from a GP sort of perspective, sort of being the one that might know the patient the best and sort of see them the most as well, or sort of get all the information from sort of all the different like allied health or specialists, and be able to sort of put those all together and coordinate them, as Gordon's mentioned as well. That collaboration process is really important. And Constance has mentioned communication as well, ongoing basis. And yeah, definitely medication management is a big part of it as well. So yeah, this is what I sort of written down as well. Probably could put education in there too. That's a good one. But I guess sort of detection of palliative care needs earlier as well. And sometimes even some advanced care planning or discussion of goals of care and how that might evolve over time can be part of that too, even if they don't really have any sort of physical or psychosocial needs at the present time. Sort of coordinating care, reviewing medications and rationalizing them as well, sort of what's appropriate and considering like prescribing as well if needed, and deciding sort of when or if to refer to specialist palliative care services, and ensuring supports in place for carers and loved ones. And can be useful to have a bit of a plan in place, sort of in hours or after hours, and important contacts in case there is deterioration as well. So I'll sort of go through sort of the stages of sort of illness as such. So this is from the RACGP Silver Book, which is a great resource for not only palliative care, but aged care in general. So illnesses can have various trajectories, and this is sort of a bit of a simplification of how three of those might look. So the first one being sort of more things like cancer, for instance, where it's quite can be quite a rapid progression and decline. The second one is more sort of chronic illnesses, so chronic organ failure. So things like chronic kidney disease as you approach sort of end stage renal failure, chronic liver disease, COPD, as you get to end stage as well, can sort of have this trajectory. And then the other one would also be like CCF, for instance, where you have a much slower trajectory and there might be some acute episodes, but then no recovery, but maybe not quite to the level where they were at previously. And the third trajectory is sort of a lot slower, sort of more around sort of dementia or sort of multi-morbidity or frailty as well, where it's a lot more gradual too. And then there's also a few different stages which are sort of talked about in that palliative care setting as well. Sort of the stages of being unstable, deteriorating, terminal, and sort of that bereavement stage. So the stable stage where sort of symptoms and any sort of other issues are pretty well controlled overall. And there isn't really too much in terms of major intervention that needs to sort of take place to stabilize people, address their issues. Unstable is when people do develop a new sort of problem, or there's been quite a quick deterioration in terms of the severity of their current health concerns, such as, for example, exacerbation of COPD or CCF. The deteriorating stage is where there is a sort of bit of a functional decline that's quite evident compared to previous. And terminal is probably more where end of life care comes in, where death is likely probably within sort of days as such. And that bereavement is when the patient has indeed passed. And that's more for carers and loved ones as well, where that bereavement and sort of grief support and counselling is offered to them. So next one. So I don't know if going through medical school you had lots of mnemonics to remember things. This is sort of one that's sort of more UK based, but I just found sort of quite useful to sort of look at and to sort of frame when you are doing a bit of assessment terms of someone who might have palliative care needs or does have palliative care needs, into sort of the different domains you would consider. And I guess with sort of general approach in general practice, when you are seeing patients, do you have that holistic approach where it's not only looking at the physical symptoms, but also looking at the emotional or psychosocial side of things as well. So looking at the person as a sort of whole and not just sort of their physical signs and symptoms. So this one is mnemonic is called Pepsi Cola. So it just goes through, can be useful to have sort of things that you might consider and some few questions as well that might be useful to sort of prompt further discussion of these different ones. So you can have a bit of a read through as well, sort of time. And then this one's a bit more education and I guess assessment of sort of capacity to make decisions as well. Ongoing care needs, aftercare. And for these next ones, they're just sort of some symptom scales and things that can use to consider. This one is just nice to sort of work through in a consultation if they have any sort of particular concerns that, you know, that they might like to discuss, and, you know, might help to prompt the patient as well. And sort of rating scale for sort of distress levels. And next one, so more sort of assessment scales that were sort of used in the hospital as well as the sort of community palliative care setting. Whether or not it might be helpful to consider it in GP practice or not, but just goes through sort of more of a functional assessment. So you have a couple different ones. There's your AKPS and your RUG ADLs. So it's just looking at, it can be useful to sort of assess over time as well, you know, how a person is able to sort of carry out their activities of daily living and sort of act as a bit of a guide as to sort of the stages that we were talking about earlier, sort of that stable, unstable, deteriorating, terminal stage as to sort of where we're sort of at with that. And then there was the RUG ADLs as well, which I saw used more in sort of the Gosford hospital sort of consult team setting, where they do see patients from other teams to sort of provide advice on palliative care symptom management or psychosocial management, sort of advanced care planning, or to take over those patients. So sort of generally bed mobility, toileting, sort of transfer, eating side of things. So looking much more at that functional assessment and decline. Go a bit into sort of symptom management side of things. So obviously there's a lot of symptoms that can be part of various sort of conditions that we sort of all mentioned in the chat earlier. Chosen to focus on some of the main ones that we'd see more commonly as well. And probably ETG is one of the sort of best resources. There's also some apps you can download, like the Palliative app, which can be helpful as well. It's a bit of a guide. So I guess in terms of pain, good to sort of first work out what kind of pain a person is having to sort of better guide what kind of medication options you might consider. Certainly in terms of like nociceptive pain, or if it's more neuropathic pain where it might be more burning or tingling or feel like sort of electric shock. And I guess as always, looking at the sort of functional impact of pain as well. And obviously important to look at first things first, I guess that simple analgesia, if that's maximized, and using sort of non-pharmacological strategies as well to consider for pain management too. So I guess heat cold therapy, sort of stretching, mobilization, whether a TENS machine might be appropriate, and some psychology as well, such as CBT can be helpful as well in terms of non-pharmacological strategies. And if that's inadequate, consider starting opioid medications. Usually when patients are sort of opioid naive, and if their renal function is okay, generally opt for either morphine or oxycodone at a low dose. I know certainly, I don't know what everyone's preferences are, but certainly in the community, I tend to use oxycodone more, or at least before doing the palliative care scholarship. But I guess the important thing to consider as well is the metabolism of oxycodone tends to vary a bit more amongst the general population. So some people are quite rapid metabolizers, so they would need sort of higher doses compared to other people because they just burn through it really quickly, and some people really slow metabolizers as well. So it tends to be a bit less variation, which is why usually the palliative care team tends to go for morphine first, but everyone's a little bit different and has a different approach, which is perfectly valid. And usually if a person is opioid naive and their eGFR is pretty good, say it's over 40, starting with sort of immediate release PRN doses, and then sort of aiming to convert to slow release, depending on how much they use. If they're only using it quite sparingly and not needing to use many doses at all, or not even sort of might not necessarily have a dose a day, they may be sticking still with the PRN or breakthrough doses. And otherwise, if they are needing quite a few doses, looking at incorporating like a slow release of regular opioid along with the PRN option as well, once you get an idea of how much they're needing to use. In terms of other opioids as well, so there's buprenorphine and fentanyl as well, which can be more your transdermal or patch options too. So it can be useful if the patient is unable to swallow, or they might have issues with absorption from the gut, or they just find it difficult to sort of take their pills sort of quite frequently. If considering fentanyl patches, generally they need to be at least on sort of 30 milligrams of morphine in a 24-hour time frame before considering fentanyl, because obviously it's a lot stronger. In terms of things, tramadol at this stage is a pretty limited role in palliative care pain management, not quite as effective as morphine for cancer pain. And there's a bit of a limitation in terms of dosage and how far up we can go. Tapentadol or Palexia are still sort of evolving evidence for its use. is used sometimes, but it's a bit of a sort of case-by-case basis. And codeine also has quite a limited use in the palliative care setting. But certainly if someone is not opioid naive, so they're already on, say, tapentadol or tramadol or codeine for sort of other issues, or perhaps existing for analgesia, and it's working well for them, generally it's suggested to just keep them on that dosage and reevaluate if their sort of pain isn't sort of well managed. And then if switching to sort of subcut administration, if they're unable to swallow, you'd use generally half the total of the 24-hour dose. This is more in the sort of hospital setting as such, or end-of-life care as well. And certainly with sort of end-of-life care in the community setting, the community palliative care team usually does provide sort of medication, kits, equipment as well, and sort of educates the family on how to administer that too. So next one, I guess other considerations for pain as such is, if palliative radiotherapy is an option as well. Steroids, so dexamethasone, can be useful for pain in certain situations. So increased intracranial pressure can also be used for nausea and vomiting in the setting of increased intracranial pressure, sort of liver capsule stretch pain as well. For liver malignancies, tenesmus too. And opioid rotation is sometimes used as well when opioid tolerance develops or sort of adverse effects occur. And obviously be mindful of those, which I'm sure you're aware of as well, sort of obviously bowels, constipation, drowsiness, nausea, vomiting, confusion, and hallucinations. And neuropathic pain, obviously you can look at neuropathic agents and nerve block as well. This is just a bit of a nice sort of little table flow chart in terms of considerations for pain. So sort of that those different like non-pharmacological, pharmacological, sort of other sort of interventional therapy, radiotherapy, and education as well to consider. And these are the different pain scales which can be useful. Obviously, there's sort of that 0 to 10 sort of severity rating that we tend to use day to day. You can also use sort of this FACES pain rating chart, which can be useful. And this can be the Abbey pain scale is more useful for people who might not be able to communicate verbally their pain for whatever reason, whether they do have existing intellectual disability or have dementia, for instance. That's can be useful. So looking more at sort of behavior, body language, things like that, and physical changes that can be useful as well to determine how much pain they're in and just help with medication titration. So this is from ECG, so just looking at sort of initial PRN breakthrough opioids. So obviously, usually choose between morphine and oxycodone, sort of immediate release. And depending on sort of obviously the age, kidney function as well, and also the other medications as to how much you would start with as well. So obviously with your morphine immediate release options, you have your sort of Aldine liquid, and then oxycodone, you have your sort of oxynorm or endone as well. And then sort of regular opioid, so based on that sort of PRN dose and how much they are using in a 24-hour period, sort of figuring out if they do need a regular opioid and what you might consider starting with. So for instance, your MS content for your morphine or your Capanol as well can be a consideration. And for your oxycodone, you have your OxyContin or Targin as well. And transdermal options, you have your buprenorphine and your fentanyl too as well. And these are just your neuropathic agents, which I'm sure you're well versed with. Various options. In terms of opioid conversion, so this is issued from the CCLHD sort of opioid switching guidelines, which are quite good. So it just goes through general sort of ratios as such. There's also sort of your opioid conversion calculators. So there's a few out there. You have your EVIQ, and there's also one from the Faculty of Pain and Anesthetics as well. I believe there's an app you can download too. And this is just a nice table as well. So these are all sort of written by the palliative care staff specialists in terms of switching from various medications. If you're switching to patches, for instance, or changing up the frequency of opioid medication as well. So how you'd approach that and when you would give the sort of next dose as well. Be useful to look at. And I guess the other thing to note as well is when you're switching to a different opioid, generally a dose reduction of 30 to 50% is recommended just in case there is a bit of difference in metabolism, and obviously having that PRN available as well to help sort of titrate and stabilize on a dose in particular. This one was just from Western Australia, so it's another sort of opioid conversion guideline as well. It's available. So the other common symptom as well is shortness of breath, so dyspnea, which a lot of the time can be sort of multifactorial. In terms of non-pharmacological strategies, there's rectangle breathing. So that's where sort of you breathe in and then you sort of exhale for sort of twice as long as your breath in. And then another sort of breath in and then sort of exhaling again twice as long. So lots of breathing strategies can help. The recovery or tripod position sometimes can be helpful as well, especially if they do have some COPD. Energy conservation too, a handheld fan or some kind of airflow and ventilation certainly can help too. And managing any anxiety as well, because certainly that can be a bit of a cycle with shortness of breath, sort of can obviously increase anxiety, which can sort of feed into that breathlessness and sort of be a bit of a vicious cycle. In terms of medication options as well, can consider morphine is probably the most common one as a sort of first line option. So normally something like Ordine is used. Can use sort of midazolam, sort of your benzos as well as second line options. And oxygen sort of depends on the saturation levels and what kind of condition they have. If they are retaining CO2, obviously you don't want to give them too much oxygen, so the saturations will be aiming more between 88 and 92% rather than the high levels. And sort of obviously optimizing if they are on any puffers, optimizing those medications too. And if there is CCF, obviously diuretic titration to manage any fluid overload as well can be useful. And nasal pro-oxygen obviously can be helpful, but being short of breath doesn't always indicate that a person is hypoxic or desaturating, and likewise oxygen might not help improve shortness of breath as well. So this one just sort of is a bit of a guideline in terms of things that might be considered for managing shortness of breath as a starting point. So obviously you have your PRN doses so as required, and then you can consider based on whether this is effective or not to incorporate a bit of regular opioid. So generally, if they're needing sort of 3 or more sort of doses of PRN morphine, and they are finding that it does help with their breathlessness, considering either introducing a regular opioid or increasing the dosage of any existing opioid. And morphine does have more evidence for helping with shortness of breath such. Generally, the cap for morphine helping with breathlessness is about 30 milligrams. So once you get up to 30 milligrams and they're still not getting a lot of relief from that for the breathlessness, or not quite enough, generally suggest seeking sort of additional advice, or looking at any other potential causes such as sort of anxiety, and whether you might consider adding in an anxiolytic such as midazolam or benzodiazepine to help with that as well. So the other one that's common as well is nausea and vomiting, which is quite dependent as well on sort of the cause of the vomiting. So one of the common causes is poor gastric emptying or constipation. So it can be due to if there's a lot of malignancy that causes pressure, also effects of medication as well. Smaller, more frequent wheals can be helpful, and usually we'd go for something like metoclopramide or domperidone as well, which can be useful too. And if it's more of a sort of central cause, be looking at things more like haloperidol, can certainly look at Maxilon as well, and sometimes Stemetil. So these causes are more from like a metabolic disturbance, so such as in CKD. And intracranial causes, so increased intracranial pressure, which I mentioned previously, or sort of direct mass effect of tumours. You'd consider options like dexamethasone as a first line, and then you can add in some haloperidol as well if the dexamethasone on its own is not quite enough. If there is quite sort of severe intracranial pressure rise or sort of risk of herniation, usually a higher dose of dexamethasone would be used as well. And obviously considering sort of specialist input if that isn't already in the picture. And I guess just a note for Parkinson's disease as well. So obviously your metoclopramide, so dopamine antagonist, shouldn't be used in Parkinson's disease or Lewy body dementia because they can worsen a lot of the symptoms as well. You can consider domperidone as it doesn't cross the blood-brain barrier, or otherwise ondansetron if there's no contraindications or interactions with any existing medications. So that's that. And then just be good to have a bit of a discussion. So I guess maybe if people do want to unmute or type in the chat box, either or, just like to check and see, how people do approach advanced care planning with their patients. I know it's something that certainly didn't sort of consider a lot before doing the scholarship, but then afterwards I've been trying to do sort of more talks about sort of goals in care and advanced care planning sort of a bit more proactively with my patients. So yeah, I'd just like to see how everyone approaches it.
Yeah, yes, thanks, Cindy. Yeah, so as Chrissy mentioned too, yeah, we often do it as part of our 75 health assessment.
Yeah.
So we usually give them a little booklet and go through it with them. Some patients have already sorted it all out and have got it scanned in their notes, but yeah, others are quite reluctant. So but yeah, I think we give a booklet, I think similar to what Gordon's just mentioned there, the New South Wales health document.
Yeah, definitely. But yeah, 75 health assessment is a great chance, or also as sort of diagnosis and prognosis comes up as well. And yeah, thanks for that resource as well. It's a good one too. But yeah, there's lots of great sort of resources on advanced care directives. And I guess how I approach it as well is sort of it's sort of like a will. So it is a sort of legal document when it's all signed, but it can be sort of changed at any point in time as well. And just to make sure sort of wishes for, what they'd like and their values to be respected. And I guess also to help family or their enduring guardian make decisions as well. Because obviously there are some medical decisions that can come up that people might not ordinarily think of as well. The other one, I guess, that is part of advanced care planning is sort of where people would prefer to die as well if their health did deteriorate. So sort of that end of life care, and which I hadn't really considered the full logistics of how sort of end of life care would look at home. Obviously, quite a lot of people might prefer to stay at home for end of life care. But sort of going out with the community palliative care team and sort of having a lot of those advanced care planning, goals of care, sort of end of life care discussions as well. So generally for end of life care at home, obviously palliative care team is able to do lots of home visits, loan equipment as well, provide all the sort of medications, equipment, sort of subcut syringe drivers, all of that as well. But generally they would need sort of two like physically capable adults to be around for cares as well. So also, especially if they, are bed bound, to be able to rotate them and be mindful of sort of pressure areas or cleaning them as well, sort of toilet cares, all of that too. As well as to sort of monitor symptoms, administer medication as well. So it is does involve quite a lot of effort, and sometimes people realise they aren't able to sort of do that in sort of the home environment as well. But yeah, great resources as well. And for the next one, I'll just new slide. So just want to make a mention as well of sort of different population groups and sort of particular considerations. Obviously, sort of intersectionality can play a big role in healthcare as we sort of consider how, Aboriginal and Torres Strait Islander populations. There are health inequities and disadvantages, lots of barriers for accessing good healthcare as well. And the other one as well is sort of cultural and linguistically diverse populations as well, where there are additional considerations for palliative care and end of life and bereavement as well, which I guess at the end of the day, each person is really individual too, and obviously palliative care is really individualized and looks different for every single person. So I guess obviously checking who they would want to be involved in discussions about their healthcare as well, any important sort of family or cultural practices that are important or will be happening and how to sort of support that as well. And those are some great resources as well about particular considerations. And I guess also checking sort of what terms are preferred about sort of dying and death or sort of deterioration, sort of being terminally ill as well. Because in some Aboriginal and Torres Strait Islander communities, they would prefer not to make direct statements about dying and death as well. And I guess discussion on location of passing. So for some, it might be really important to them that they pass on country and are buried on country. And I guess how to navigate that as well. And also sort of mentioned a bit more about culturally and linguistically diverse populations and some more resources about that as well. So again, checking who they like to be involved in discussions about their healthcare. And I guess in some cultures, sometimes the patient might prefer not to know as well about certain diagnoses or prognosis as well, and prefer more for the doctor or the family to be making decisions as such. And even within a cultural sort of or ethnic group, there may be sort of variations in their beliefs, values, expectations, and expectations around healthcare and sort of interpreter and translation services as appropriate as well. And I've just got some more information about loved ones and carers as well. That can be helpful as well. Certainly sometimes there can be a lot of focus on the individual and the patient, whereas loved ones and carers sometimes might feel really stressed and overwhelmed and not sure where to sort of turn to for help themselves. I do have a bit of a case study, but in light of the time, I just wanted to check if anyone had any questions or wants to discuss anything in particular before we go ahead with the case study.
Cindy, I just had a quick question just about
Yes.
voluntary assisted dying. Did that
Mm.
come up very often in your palliative care term?
No, it didn't come up a lot. Usually it's a separate sort of service as well. So they said if you do have a patient who does want to sort of explore, look at voluntary assisted dying, but does have palliative care needs as well, to actually put in both referrals. So the community palliative care team, they look more at sort of palliative care, sort of symptom management, advanced care planning, goals of care, end of life care, those sorts of things, psychosocial sort of allied health input, but they don't do VAD themselves. So it's actually, if they do get someone who requests VAD, they would actually then need to make a referral themselves to VAD, which obviously has a bit of a wait time as well. I mean, they're happy to do it, but they said if a patient is, quite interested or would like to proceed, have assessment with the VAD team to make a referral to both teams, if that makes sense.
Yes, thank you.
Yeah. Any other questions?
Just on that point, sorry, Chrissy, here,
Yes.
my camera's not working.
Yeah.
Yeah, I know when I discussed with the palliative care team when voluntary assisted dying first started, it was a very deliberate decision to keep that separate. Because obviously people entering palliative care are sometimes anxious that they're going to be, put to death or their death will be hastened, and not everyone, agrees with voluntary assisted dying, and they didn't want that to be associated with the palliative care service, which I think is a really important point. They will refer if patients request, but they don't participate in that program for deliberate reasons.
Yeah, no, that's a great point to mention, Chrissy. Yeah. Any other comments or questions? Right. We'll go to a bit of a case study as well. And feel free to just unmute. And this is just a bit of a sort of discussion. There's not necessarily sort of right or wrong as such. Everyone will have a bit of a different approach. So this was sort of based on one of the home visits that I did while part of the PHN sort of scholarship. So it's a 74-year-old gentleman, diagnosis of locally advanced urothelial carcinoma, metastases, involvement of the rectum and peritoneum. He has both a colostomy and a urostomy in place, and they both have good output. But he's been complaining of increasing anal pain and passing mucus as well, occasionally tinged with blood. The pain is improved after passing mucus. He's on sort of MS Contin, 10 milligrams BD, PRN Ordine, 4 milligrams, maximum 8 doses, and he's used about 5 doses in the past 24 hours. He finds that the medication, while it has been really helpful previously, has been finding it less effective as of recent. And I guess in terms of, treatment for his urothelial carcinoma, he sort of, there's not much more that they can offer. So it's more just sort of symptom management at this stage, which is what he would want as well. So he'd prefer to be kept comfortable, sort of manage his symptoms as well as possible. Just wanted to check how people would approach his pain management. Yep, titrate up his MS content. Yep. Because he's still on a lower dose, so there's certainly room to increase up and see, especially based on, so you can use the breakthrough medication as a bit of a guide, as in how much he's been using, to get a bit of idea. Obviously useful to look at the past 24 hours, but just to look sort of in the previous few days as well, how much they've been using. That's been quite consistent. So obviously he's used 5 doses of the 4, which would be 20 milligrams of the Ordine in the past 24 hours. Yeah, definitely. Examination, really important. Yeah, if there's any other cause for his pain as well from boys, hemorrhoid. So yeah, that's definitely great. 2, excluding other causes, just because the pain's increasing doesn't necessarily mean it's just sort of related to sort of malignancy diagnosis or the condition that they have. Might be something else going on. Really important. And yeah, definitely great suggestion, Chrissy. So role for topical anal analgesics, so like proctocidal. It's definitely a great consideration, and that's what the palliative care team did start him on as well. And Gordon mentioned changing to patches for better 24-hour coverage. Yeah, that's also a great thought. I guess especially in his case as well, because there is involvement of the rectum as well, and he does have that colostomy in place. Whether there is a bit of impaired gut absorption was what the palliative care team was sort of discussing, and whether sort of a transdermal approach might be worth considering if he just isn't absorbing enough of the endone through the GIT system. So looking at things like buprenorphine, it's probably a bit tricky. He's maybe not on quite enough morphine. You might consider potentially low dose fentanyl patch, but he's probably sort of just on sort of 30 or yeah, just on sort of 40 milligrams of morphine. But you could consider that as well, and you could chat with the palliative care team if you just wanted some advice or just to double check doses and things. And yeah, certainly rectal mass. Georgia mentioned if it's increasing in size, certainly dexamethasone radiotherapy would be good to discuss if that could be considered as well. And Chris has mentioned whether the pain has any neuropathic component. Yeah, that's always great to check as well, to check the character of the pain and whether sort of adding in a neuropathic agent as well would be helpful. Definitely. And Constance has mentioned, yeah, nature of stool. Still important to sort of consider it as well, I guess, in general. Obviously, being on quite high dose of opioid constipation is always a big consideration, and obviously that can make things like pain worse, as well as nausea and vomiting as well, if that's not well managed. It's a great point. And in terms of switching, from morphine to oxycodone. So just said that in terms of not that you'd necessarily switch in this case, but just to sort of talk through, I guess, in terms of switching doses and what you might sort of consider. So thought in terms of if you were to switch from morphine to oxycodone slow release and PRN, what doses you might be looking at? I guess as a starting point, you would first work out how much morphine he's been having in the past 24 hours. So he's having 20 milligrams in total of his slow release regular opioid, and then also 20 of his breakthrough medication in the past 24 hours. So that would be a total of 40 milligrams of morphine. And it might be helpful if I maybe try and go back to, I try and find my chart. A lot of the conversion from morphine to oxycodone. So I guess in terms of things, so morphine to oxycodone, the ratio is generally 1.5 to 1. So if he is on sort of 40 milligrams total, it'd be sort of equivalent to about 26 milligrams of oxycodone. But obviously when you're switching opioids, if you're not sure how they're going to metabolize the new opioid, you would consider sort of that 30 to 50% dose reduction. And then obviously have the PRN breakthrough as well to just help with dose adjustment. So with that 30-50% dose reduction, sort of a bit depends on, whether you want to go more with the 30 side of things or 50%. But then either you'd be looking at about sort of either 20 milligrams or then sort of a bit lower as such. And then obviously having some breakthrough. So usually with the breakthrough medication, if they are on slow release, you'd consider having the dose about 1/6 of their sort of 24-hour sort of slow release dosage as such. And if we go back to the case study, are there any other sort of considerations, I guess, before we finish up, that you would consider with the patient that you might check for? If you want to, feel free to put in the chat or unmute.
So checking for other symptoms like nausea as well,
Yeah,
appetite.
yeah.
As we've discussed, end of life care or advanced care directives. So just in terms of forward planning with his management.
Yeah, definitely. It's great. So yeah, advanced care planning, goals of care, always good to sort of revisit as well when things do deteriorate or change as well, just to see if they want to adjust or change anything as well. And yeah, definitely checking for any other physical symptoms, nausea, vomiting, pain anywhere else that's not managed as well. And then I guess other one is as well that's also sort of commonly forgotten is sort of mouth as well. So sort of mouth cares, if their mucous membranes are quite dry, if they have any thrush. And commonly what's used is sort of the aqua sort of mouth spray, biotin gel, especially as Georgia mentioned, sort of appetite sometimes if that's quite reduced, or they are feeling a little bit nauseous and they're not really having much in terms of food or fluid as well. So that's also a good one. And then I guess just checking how they're managing sort of emotionally as well, if they want any sort of counselling, psychology support. And Chrissy has mentioned ability to swallow as well. Yeah, also really important. And delivery systems obviously too. So if he was finding it quite hard to swallow, maybe looking more at sort of obviously liquid formulations if that was suitable, or if we'd have to look at sort of transdermal options or subcut options as well. And yep, side effects is also a good one. And also monitoring for any opioid toxicity, sort of oversedation, pinpoint pupils, things like that. Lovely. So that's end. Those are some great resources as well. More, lots of great resources. But yeah, any other questions, comments?
It was fabulous, Cindy. That was such a good overview and fantastic to get your experience from doing your palliative care scholarship as well.
Yeah,
some great resources that I'm sure we'll use. And, again, general practice, I know myself, I only might have one person every 12 months that I have a palliative care patient, and it's a steep learning curve. You feel like you're on top of it and then you forget for the next patient. So it's great to have these resources at our fingertips when we need them. So thank you, Cindy.
No, thanks so much for having me and appreciate everyone's input. Definitely really nice to have that.
Thank you, Cindy. Thank you, Cindy, for a wonderful presentation. It was really, really good. Enjoyed it.
Yeah. Thank you. And hope everyone has a great rest of the day and week.
Absolutely. Have a great day, everybody, and see you in 2 weeks' time for another vertical integration.
See you in 2 weeks. Thanks, Cindy,
you.
again.
Thank
Thank
you.
you.